Good morning again, everyone. Welcome to our annual conference. This is our 11th conference for the Maryland Sleep Society and our first virtual conference. We're really excited to have you here. We really missed you last year. Next slide, please. First of all, I'd like to thank our sponsors. You can see them listed here: Harmony Biosciences, Jazz Pharmaceuticals, Fisher Paykel, Inspire, ResMed, Itamar, Natus, Respicardia, and Vyaire Medical. We really appreciate their support. Without their assistance, our mission and our conferences would not be possible. I'd just like you to know that our platinum and gold sponsors will be having virtual booths. The virtual booths may be found at our website at the MarylandSleepSociety.com website /exhibitors/. Next slide, please. So I just would like to give everyone just some basics. I think as an attendee, there were 3 questions that came to my mind. Number 1 is, how do I ask a question? We have our process set up where attendees will be able to place questions into the chat box. And so we will have a moderator who will be presenting our speaker and also reviewing questions. Questions will be reviewed and they shall be posed to the speaker at the end of their presentation so that you have a nice, smooth presentation without any significant interruption. Lectures for the 1-hour talks will be approximately 45 to 50 minutes in length, with the remaining 10 to 15 minutes for questions. We ask for, again, your patience and indulgence. We know that there will probably be more questions for our speakers than time will permit. We will do our best to screen the questions, try to see if we can maybe synthesize 3 questions into maybe 1 basic question to ask, forward that to the speaker, and do our best to try to answer the questions from the audience. Next slide. During our breaks this morning, we're going to have our virtual booths available. One of the things I think we've all missed is human interaction. I know we've used Zoom or we've used virtual meetings as a substitute like right now. We would like our attendees to have an opportunity to spend time with our sponsors. Our sponsors are really looking forward to spending time with the attendees. They miss you guys. So what I wanted to share with you is to say, look, if you go and find the virtual booth, exhibit booth, which is located on the website, you will see that under the name of the vendor, you will see that it says visit virtually using this link. If you click on that, that will allow you to make a connection to another meeting that will be held. Meetings for the vendors are separate from the continuing education that is required by AASM for our continuing education credits. You will be able to access vendors through those sites. The times that vendors will be available are from today from 10:30 to 10:45 and from 12:45 to 2 p.m. today. Tomorrow, the vendors will be available for 15 minutes between 10:15 a.m. and 10:30 a.m. We are offering raffles for attendees who do spend time with the vendors. The vendors will collect your name. They will put that in so that we can see about offering door prizes at the end of the conference. Please let the vendor know that you are present when you attend their link. Thank you. Next slide. Last question. How are you going to get CME? We have been working with the American Academy of Sleep Medicine. They are going to provide the CME for this conference. At the end of the conference, we will be forwarding you a survey, and we will also provide further explanations on the details on how you can apply for your CME at the end. Please enjoy your conference. We are grateful to have you here. I think we have a really good group of speakers. I hope you really enjoy yourself. And really what I just wanted to say is enjoy. We hope to see you in the fall. We hope to do this in person. We hope we can shake hands. We hope we don't have to wear masks at that time, and maybe we can even break bread and have a conference the way we've always known it. Thanks for being here. I'm done, Clara. Thank you. We can go back now to our slides. We will start at 8:15 with our first speakers. Thank you.
Hello, everyone. My name is Brian Robertson. I am one of the Maryland Sleep Society board members and a sleep physician, and I am going to be the moderator for our first session, which is a literature review with some highlights from the last year in literature. We have 3 fellows presenting in the next hour, and I'm going to introduce everyone. After each speaker, there'll be a few minutes to answer any questions that you might put to us, so please write those questions in, and I will read them off and let our fellows have a chance to respond. Our first speaker is Dr. Jeremy Gutierrez. He is a pediatrician and a sleep fellow at George Washington University and at Children's National Medical Center. So I'm going to let him go ahead and start.
All right, thank you very much. Next slide, please. I don't have any conflicts of interest to send. So the first article I will be reviewing is one on a high-flow nasal cannula for treatment of, let's say, in infants and young children. And the authors are Daniel Ignatiu from Cincinnati Children's and the group from the University of Utah. So the current treatment options for OSA in children, include surgery such as TNA, and medical treatment including CPAP. CPAP alleviates the upper airway collapse. However, the effectiveness can be limited because of difficulties with adherence, especially in the young kids, and the adverse event of mid-phase hypoplasia, and particularly in those who need prolonged use of CPAP therapy or high pressures. This far, there's really limited data use of the use of high-flow nasal cannula in the home setting for OSA treatment among the younger kids, so the infants and the young children. So this study, the main study aim was to determine the effects of high-flow nasal cannula on OSA among a group of infants and young children, both in the sleep lab and at home, and with the hypothesis that treatment with high-flow nasal cannula can alleviate obstructive events, and it can be well tolerated at home. So this was a retrospective study of patients that were diagnosed with moderate to severe OSA and that were treated with high-flow nasal cannula. So all of them had an initial diagnostic sleep study. For a subgroup of those who had a surgical intervention, they used a post-op baseline sleep study, and then they had a high-flow nasal cannula titration study. After the titration study, then most patients were recommended to go home on high-flow nasal cannula by using the lowest airflow rate that alleviated the obstructive events. So they used from 4 liters to a maximum of 12 liters per minute, and their goal was to have a period with an OAHI of less than 5. So this is a table 1. This is just the age at the moment of the diagnostic study was a median of 8, and then at the moment of the high-flow nasal cannula titration with a median of around 12.8 months. Now, other characteristics of these children are that about a third of them had a prior surgical intervention. 9 or 41% of them had trisomy 21. The majority of them had dysphagia or swallowing dysfunction. Minority of them, 14%, had chronic lung disease, and about a third of them also had history of preterm birth. So this is comparing the diagnostic and the high-flow nasal cannula titration study. And as you can see here, mainly looking at the sleep architecture, the length of total sleep time in REM and non-REM was significantly higher during the titration study. And the sleep efficiency was higher, but not statistically significant. And here it's important also to look at the moment they reach to the therapeutic flow, which is what they use to calculate the indices of improvement. The amount of total sleep time, clearly was low, like 106 minutes per median. And then the time in REM was also low than 4 minutes, non-REM about 82 minutes. And below we're seeing the comparison of the obstructive indices during comparing the diagnostic study to the titration study when they reached the therapeutic flow. And as you can see, there was a dramatic decrease in these indices in the AHI, the OAHI, the OAI, and the OHI. Also, they all had significant increases. However, when looking at the central apnea index, this was not really significantly different, even at therapeutic level with high flow nasal cannula. This is another way to see the same results, just highlighting the dramatic change in all of these indices, except for the central apnea index, where when looking at the whole group together, there was not really a significant difference, although there were 5 of those kids that had worsened central apneic events when receiving high flow nasal cannula. So out of the 19 patients that were prescribed home high flow nasal cannula, at the 6-month follow-up, about 16 patients were eligible to be continuing high flow nasal cannula, and about at the 12-month follow-up, around 12 patients were still eligible for high flow nasal cannula. Those 7 patients were either lost to follow-up or they had a response or resolution of their OSA. The most common complication in this group was the cannula dislodgement, and then less common complications were restlessness, skin irritation, or desaturations, dry lips, low heart rate, or abnormal breathing. So high flow nasal cannula alleviated the upper airway obstruction of these infants and young children with diagnosis of moderate to severe OSA. However, high flow nasal cannula was not effective in treating central sleep apnea. The high flow nasal cannula was also tolerated in majority of the patients who were recommended home treatment. However, they had a reported adherence to high flow nasal cannula compared to CPAP, so it was similar. However, the way they measure adherence was in a subjective way. The OSA results in some children over the 1-year period. So some of the study limitations, this clearly was a retrospective chart review. We didn't really have a comparison group, let's say with a group just treated with CPAP or treated with low flow nasal cannula. A subgroup of patients also had the addition of supplemental oxygen into the high flow nasal cannula airflow, so this could affect the interpretation of the oxygenation data. However, it was only the ODI that differed between the patients that received or did not receive supplemental oxygen. Also, another limitation is the time from diagnostic to the high flow nasal cannula titration study. So as you saw, the median was around between 7 to 8 to 12 months. So there was a period there of 3 months in between that, perhaps at least partly of the improvement of the obstructive event could have been because of growth. And lastly, adherence was assessed subjectively by caregiver report. So that was not really an objective way to see how well they used this. So in conclusion, the high flow nasal cannula is an effective medical therapy for OSA among infants and young children, especially those who are not candidates for surgery or who have residual OSA following surgery or who do not tolerate the standard, which is CPAP. And then further research is needed to establish the role of high flow nasal cannula in the treatment of OSA among children in different age groups. All right, so that was the first study.
Oh, hi. So we have one question about that study before we move on. What is the mechanism by which high flow nasal cannula seems to improve sleep apnea? Because we're not increasing the pressure in the upper airway, so there must be some other mechanism. Is it stimulation?
Yeah, so one of the ways they thought it was just because they were using relatively high flows. They proposed that perhaps there was some stimulation or perhaps a little bit of a PEEP or more of a dynamic PEEP. That's one of the things that they discussed. And then the other thing really is that they used a subgroup of patients where they actually gave supplemental oxygen. So now these kids had some other chronic illnesses, but that definitely could have prevented some underscoring of perhaps some of obstructive events. So perhaps really masking the true efficacy of treatment of OSA with high flow alone. So they didn't really specify how many of the kids received that supplemental oxygen.
Okay. All right, thanks. Let's move on to the next one. Good.
Okay. All right, so this second study is from the group of Children's National, Miriam Weiss and et al. And it's defining the patterns of PAP adherence in pediatric OSA, a cluster analysis of using real-world data. So the implementation of PAP therapy and adherence in children is complex, so we have significant difficulties with PAP adherence. And there's really a critical need to develop a personalized approach to optimize PAP therapy in OSA. Traditionally, we use PAP downloads with some single cutoff parameters to see how well they're doing during their PAP usage at night. So we use, for example, at least using 4 hours per night, or looking at a period of time and see how many nights they're actually using it over a month or 2 months. So the aim of this study was to try to subgroup pediatric PAP users using a clustering analysis and detect what their pattern of use is, and with that, guide some tailored interventions. So this was also a retrospective study. There was 250 children from 1 month to 18 years of age, so a very wide age group. The group collected demographic, clinical variables, mass type, in-office mass tolerance, sleep study parameters for baseline PSG, and then PAP download data. The core 2 variables that were used for the cluster analysis was, one, the PAP tolerance, which was defined as average hours of PAP usage over the days the device was used, and then the consistency of PAP use, so the percentage of days the PAP device was used during the recording period. And then the Ward's minimum variance hierarchical clustering method was used. This is kind of the flow of things the analysis was done. So you started with the 250 kids, then looking at both these core variables, PAP tolerance and consistency, then you do the hierarchical cluster analysis, and then that identified 5 subgroups or 5 clusters. And here I think in B is a little bit easier to understand. So in the y-axis you have PAP tolerance, and in the x-axis you have PAP consistency. So let's go to the best group, is the cluster A. So this one has high PAP consistency and high PAP tolerance. On the opposite side, you have the cluster E, which is the one with the lowest PAP consistent and lowest PAP tolerance. In the middle, you have the other ones, right? So B also had very high PAP consistency and really a little bit lower PAP tolerance, but still very acceptable. Then the cluster C had, again, high PAP consistency, so they were using it, they were making an effort using it daily, but the PAP tolerance, when looking at hours per night, was low. And then group D had lower PAP consistency and perhaps closer to acceptable PAP tolerance. So when looking, once these 5 clusters were identified, then the group looked at different clinical characteristics. And I'll just kind of summarize this with a heavy graph. But for example, for cluster A, so those were the ones that had the best adherence to PAP therapy. As you can see that they had the lowest BMI of the groups, and especially which statistically lower compared to the cluster C and E, which are the ones that with the worst adherence to PAP therapy. They also had the highest OHI in REM. And it's not there, but they also had the highest proportion of kids that underwent TNA compared to the other ones, but this difference was not statistically significant. It's not there. For cluster B, they had a little bit higher BMI, but still lower compared to the worst adherence clusters. For cluster C, these were the ones that had that relatively consistent PAP usage, but poor tolerance on a nightly basis, essentially. These kids had the highest proportion of developmental delays here, 50. And then in cluster D and E, these are the 2 clusters with the lowest adherence. So in D, they had an elevated BMI, as you can see, with a mean of 34. And they actually also had the lowest proportion of developmental delays and the lowest REM OHI compared to cluster A that was the highest one. And finally, in cluster E, these ones were the ones with the highest BMI. And then in the next slide, we'll see some of the PAP therapy variables. And as you can see here, the main thing is a cluster A, the ones with the best adherence. Now these kids had the highest PAP setting, which was the median of 8. They also had the best response to therapy with a one of the highest reductions in AHI. Then cluster B had a little bit lower median pressure with a very high tolerance to mask placement in office and low mask removal at home. So that makes sense. So they were a little bit more adherent. In cluster C, the median PAP setting, as you can see, was lower at 5.5. And despite tolerating the mask relatively well in the office, they still had high mask removal at home. So definitely something where you can act on there. In cluster D, which was now looking at the worst adherence clusters, this one had one of the highest rate of mask tolerance in the office, but still high removal of the mask at home, and one of the lowest residual AHI. So they had good response to therapy when they were actually using it. And finally, cluster E, this is the one with the highest BMI and the worst adherence. So, and these children were on a lower PAP setting, and they also had the lowest PAP mask tolerance of the mask in the office and the highest mask removal. So again, very some points there really that we can act on. So then using this cluster analysis data, then some potential interventions were identified for each cluster. So cluster A, these were the ones who were doing the best, so perhaps no further intervention, and they would be good candidates to do telemedicine, for example. Those in cluster B, then they may need a little bit of a higher PAP perhaps, or optimize at least a PAP therapy, and they may also need perhaps a TNA since they had a lower proportion of patients with TNA. And similar for cluster C, perhaps optimizing the PAP therapy or increasing a little bit the pressure. So when looking at the cluster D and E, so these are the ones that were using PAP less than 50% of the days. Again, so things that had in common was looking at obesity, could have interventions for education or behavioral modification. The cluster D may need some better PAP routine, perhaps, so more like really looking at like education, perhaps lowering the PAP in this particular cluster because they had a bit higher pressures in the beginning. And for cluster E, this was the one with the highest BMI and also had the lowest pressures. So perhaps for this group particularly, increasing the pressure and getting better treatment earlier in the night may improve adherence as well. Okay, so some limitations of this study was it was a retrospective study, so clearly we need larger longitudinal studies for validation. And we could not ascertain the exact timing from the moment of PAP prescription and initiation. And the reported clusters actually may change with age. So these clusters, however, were not different in age and other demographic characteristics. Then the efficacy of subsetting of PAP therapy clearly needs to be tested in clinical practice. And then only half of patients had titration studies. So definitely this is an important one that could have been influential in determining what was the best mask or the optimal pressure to begin with. So in conclusion, so this is a simple method to subset PAP use patterns can be implemented and to self-classify all pediatric OSA patients and to guide some cluster-specific interventions. And the PAP use patterns can be analyzed to optimize PAP therapy in children of all ages based on this real-world data. Okay, and that's the end of that article.
Thank you, Dr. Gutierrez. I actually have one question. Your talk reminded me, I noticed in cluster A that that group of high adherence, high tolerance for CPAP group had higher pressures. And it reminded me of a paper I read a couple years ago that showed in adults that higher pressures were associated with better adherence. So sometimes more is less, but maybe with CPAP pressures, more is more, it's better. It just made me think that maybe even if you turned up the pressure, maybe they would feel better. That's a thought.
Yes, definitely. And this is something that we've already, after identifying this in children, when they have poor tolerance, and we have many of these kids that have very high BMIs and they're a little older. And yes, we try to go up on the pressures a little bit earlier, and then hopefully that will treat them earlier in the night, and they'll be able to keep the masks on.
All right. Well, I thank you. Those were excellent presentations. And we're right on time. We're going to move on. Thank you, Dr. Gutierrez. And so we have Dr. Wahida Akberzie. She is a family medicine doctor and a fellow at George Washington University. And she is going to present a couple of articles. So you can take it away, Dr. Akberzie.
All right, thank you. All right, good morning, everyone. So this paper, it's called Sleep Duration Regularity, but not Sleep Duration, is associated with microvascular function in college students. Yeah, so no conflict of interest. All right, so irregular sleep duration, it may be a risk for cardiovascular disease. So it's been seen that macrovascular and microvascular dysfunction occur following repetitive sleep deprivation, especially in young adults. But it's unknown if variations in the sleep duration is associated with vascular dysfunction in young adults, which is commonly experienced in college students. So this topic, it could help kind of identify a target in risk modification in terms of preventing cardiac disease. So the aim of this paper is to evaluate the associations between sleep duration and sleep duration regularity with peripheral vascular function in young adult undergraduate students. And the hypothesis is that both shorter and more irregular sleep duration would be associated with less optimal flow, mediate dilation, so you'll see this FMD, and passive leg movement, which is a little misleading because PLM, and responses in undergraduate students. So 51 healthy undergraduate students underwent 14 days of actigraphy and then vascular assessments. So as far as what was collected was, it had to be at least 12 nights of sleep accelerometry data was required, and actigraphy data scored. Sleep diary was obtained, fasting glucose lipid profile, and then brachial artery FMD was used to evaluate the macrovascular function. And then resistance artery microvascular function was measured via passive leg movement. So that involved measuring blood flow velocity during passive leg movement, and femoral artery diameter was measured at baseline. As far as so kind of to give you kind of an idea, overall demographic group, so young 20-year-old plus or minus 1, slightly more females in this group, overall healthy in terms of blood pressure, BMI, and then you'll notice for the sleep metrics, which we'll get into a little bit more, but just kind of keep in mind when you see sleep duration SD, the standard deviation, that's really talking about the variability. So the mean variability was 1.3 hours plus or minus 0.4, and then this mean sleep duration hours was 7.1, and then we'll get into the metrics for each of those. So taking a look at macrovascular function, so when we talk about FMD percentage, so a greater percentage would mean that a better response, so a healthy vasculature. That's kind of where we're going with it. So, so a higher number would be better. And so taking a look here, so this was mean sleep duration, and this one takes a look at the variability. So in both of those, it was not statistically significant when looking at macrovascular function. You'll see the p-values on the graphs here. And for this next one, so this is looking at microvascular function using that passive leg movement. And so here, this one is for mean sleep duration, so not variability yet. And it looked at different parameters, so like peak leg blood flow, the change in leg blood flow, and lastly, leg blood flow area under the curve. And so for all of these, again, the p-values were not statistically significant. So there was not an association with mean sleep duration and PLM response or hyperemia. Now, when looking at sleep duration SD, so variability specifically, so there was statistically significant in all three parameters that were looked at. So it was inversely related. So so basically with a greater variation, there is a decrease and response in microvascular function. And that was in all of the 3 measures, adjusted for sex, BMI, and resting blood pressure. Here, we're taking a look at time, so variability. And so in this group, you'll see it's a low sleep duration variability, and that they had tended to have higher leg blood volume, so higher responses, healthier, and versus the higher variability group, which had a lower peak. So this is another way they took a look at it. So they considered low sleep duration variability to be below 1.2 hours, and then high sleep duration to be greater than 1.2 hours. And so for the first group, so you'll see in all of these parameters. So again, so the low sleep duration variability all had better values compared to the high sleep duration variability. So irregularity in night-to-night sleep duration rather than the mean sleep duration was associated with decreased peripheral microvascular function. So what does this mean? What does this tell us? So it gives us some insight on cardiovascular implications of nightly fluctuations in sleep duration, and it can give us one way of telling young adults. It can promote by promoting regular, consistent sleep schedule, it may be a method of maintaining optimal cardiovascular health. The limitations of this study, it only included young, healthy adults within a very narrow age range. They did not use any validated methods to confirm sleep disorders in this population, and it was a small sample size. Some future directions of research could be that there's needed, so why? What's the underlying mechanism responsible for vascular dysfunction in the context of irregular sleep duration, and evaluation of association in diverse population. And that's actually,
Thank you. That was a very interesting article. I'll just make a comment. We always say that regularity of sleep is really important to patients. But I just was listening to the study and I realized I don't really have a lot of evidence to say that regularity is important. What's wrong with sleeping in on Saturday and Sunday and not getting enough sleep Monday through Friday? And apparently there's a problem with that. So this is really nice research. It sounds like it's initial. You mentioned future directions of research. What do you think about another study like this? What would you want to see? What kind of study would you like to see? Further expanding on this, maybe older adults or.
I think that would be more, it'd be more helpful, especially when you get into the age group of patients with more cardiovascular risk. I think that would be helpful looking at older adults, definitely. Yeah, no, that's a very good question. Or, after, well, I was going to say after a cardiac event, does sleep variation have a greater effect? Or does it not? People with cardiac history, in terms of that, so.
And then there's some groups of people, so I think about African Americans in general who are a little bit higher risk for a lot of cardiovascular disease. I don't recall this study what the breakdown of race was, but
good question. Yeah.
Did it go into that?
Yeah, no, that's a really good question. Here, I'm trying to pull up that chart. So they actually they didn't break down that. That's a good question. Sorry, a little bad coming back to that. But yeah, but no, they didn't break down. I took a look at it myself. But yeah.
I think I want to look at higher risk people and people that had high risk behaviors like smoking or something like that, and how this sleep irregularity affects them differently than others that are young and healthy. Okay, great. Thank you. I'll let you move on to the next slide or the next presentation.
Okay, all right. So for this paper, so it's called Association of Proton Pump Inhibitor and Histamine, so H2 blockers with restless leg syndrome. Okay, so no conflict of interest. All right, so RLS, sensory motor disorder, affecting about 15% of adults in the Western Hemisphere. Low cellular iron stores appears to be a major contributor. And then proton pump inhibitors and H2 blockers are very commonly used medications, and they themselves show an evidence for causing iron deficiency. So evidence of these drugs contributing to RLS risk could suggest a need to reevaluate these use of these medications and in populations that are at higher risk of developing RLS or in RLS patients. So the aim of this paper was to investigate the association between PPI, H2 blocker medication use, and RLS risk in two groups of blood donors. So one was from the US and the other was from Denmark. And it was hypothesized that blood iron mediated the observed association between PPI and H2 antagonist use and RLS. So this was a non-case observational study from those two groups. So the REDS 3, so if you see this is the US group, that included 13,403 participants, so big group, and ages 18 and older, fairly similar between female and male. And then for the Danish blood donor group or study, so this is the final cohort that was 50,323 participants, and fairly similar as far as the male to female numbers. And so for these groups, so CBC was obtained, and they completed an RLS assessment via the Cambridge Hopkins RLS questionnaire. To ascertain whether or not they were taking PPIs or H2 blockers. So for the US group, they were asked about frequency of use of these medications. For the Danish group, they obtained via their linked prescriptions through the registry of whether or not they had filled prescriptions of these medications. It was a multivariate logistic regression that was used to assess the association between RLS and risk with antacid use. And for the US group, they included models that were adjusted for sex, age, race, also supplemental iron use within the previous 30 days, and hormone use, which those last two, the iron use and hormone use, were not adjusted for in the Danish group. Associations between PPI, H2 use, and measures of ferritin, so hemoglobin, MCV, and RBC were assessed using linear regression models. So we see, so this is the US, the REDS 3 group, and you'll see here at the top, so that's any medication regardless of the class. So you'll see the odds ratio 1.41, also one was not included, statistically significant, so in this group. When we look specifically at PPIs, same thing. I just like having this visual here. It's just helpful to kind of visualize. So it also statistically significant, and the H2 blocker. Granted, depending on the medication, in each of these classes, some of them were not, but as a class in the whole, they were. So there was an association between these medication use and RLS. For the Danish blood donor group, so again, so for any drug class, there was an association, and then for PPI use, same. However, in this group, the H2 blockers did not show. So PPI use specifically. So this actually takes a look. So we're looking at US group at top, Danish group on here. It's looking at the number of medications. So this first group, so this is any medication, whether it was 0, 1, or 2 or greater. And this specifically is looking at PPI, so and then H2 blockers. This last column didn't have enough data. That's why you don't see a bar here. But in general, the more of the medication that they were taking, the higher rate of RLS that they had. So the REDS 3 group, so they demonstrated reduced ferritin, reduced hemoglobin, and reduced MCV among the consumers of PPI and H2 blockers, whereas the Danish participants had no evidence of reduced ferritin in consumers of PPI and H2 blockers. But as a result, so the RLS, it was not, the group of RLS, they did not specifically have reduced ferritin, hemoglobin, MCV, nor RBC in either groups. So therefore, the PPI use and the H2 antagonist use was associated with increased prevalence of RLS, but not specifically mediated by serum ferritin. The lack of observed peripheral iron depletion as measured by serum ferritin may not necessarily correspond to a similar state in the brain. And then these findings suggest to reevaluate the use of PPI and H2 blockers in RLS patients. Some of the limitations, so the RLS status was measured at a single point in both groups, so it's not able to determine whether the RLS developed after exposure or it was concurrent. Exposure in the REDS, meaning for the medication, it was determined by questionnaire, so there's some recall bias there. And then in the Danish group, it used a registry of filled, and there's some bias there too, that yes, the prescription was filled, but did they actually take their medication? So that in itself has its own kind of bias. Investigators did not know the indication of their medication, like why were they taking the PPI H2? That was unknown. So there could have been some underlying condition that could be promoting their RLS risk independent of the actual medication use in itself. And then blood donors are generally healthier than non-donors. So there's kind of a healthy donor effect in this population group. So that could skew estimates of iron levels, RLS risk, or both. So future directions of research. So future studies will need to kind of untangle the cause of the association between PPI and RLS by applying longitudinal study tracking exposure and RLS emergence over time. It's kind of unknown, why is there this association? Because here, at least at this study, it didn't seem like it was mediated by iron. And, so why is it happening? And then long term, if someone's on a PPI and H2 blocker and we tell our patients to stop, is there going to be an improvement then? So much needed further, kind of further study or future directions and studies. And that's actually it.
Thank you, Dr. Akberzie. When I first started listening to this, I thought for sure it was going to be a conclusion that, higher pH levels in the stomach led to less decreased iron absorption, and that was sort of the mechanism. So it's a little surprising they didn't find evidence of that. Did the authors speculate about why PPIs and, at least in one of the groups, H2 blockers are associated with RLS?
They did. I was wondering the same thing. They didn't really speculate. There wasn't really some sort of direction as to why, because we always kind of thought it was thought and initially okay, it's likely due to iron, but no. And so it's kind of interesting, why, unless it's like the brain levels of iron, not the actual, maybe it's just not showing up on the indices that we measure,
Right.
and that's why, but that was the only thought process.
Well, it's very interesting. Thank you so much. I really enjoyed that. Okay. All right, our next speaker, and we're still right on time, amazingly, is Dr. Lacie Hediger. She is a family medicine physician and a sleep fellow at Walter Reed National Military Medical Center. And she also trained in Fort Benning, Georgia. I know that about her, which is a fantastic hospital down in Columbus, Georgia. So I'm going to let Dr. Hediger get started.
Thank you, sir. I have no conflicts of interest to disclose. So the first article I wanted to share was actually published just in September of 2020 in the Journal of Clinical Sleep Medicine. And this was a study about a randomized controlled study that was done in Stockholm, Sweden, on the use of weighted chain blankets in treatments for insomnia in patients who have various psychiatric conditions. For a little background information, so compared to the general population, insomnia tends to be more prevalent in patients with comorbid psychiatric conditions. For example, in patients with bipolar disorder, depression, ADHD, and anxiety, insomnia tends to be as prevalent in up to 60 to even 80% of these patients. The standard therapy, as we know, for insomnia is cognitive behavioral therapy for insomnia versus pharmacotherapy. However, not all patients respond to this treatment. Alternatively, the use of weighted chain blankets is being recommended more and more for treatment of insomnia, despite there being limited scientific evidence to support it. The weighted chain blankets are basically blankets where there's a metal chain sewn into them, increasing their weight. And the theory behind them is that they are sleep promoting by the fact that they provide whole body deep pressure stimulation, similar to that of acupressure or massage. Additionally, by doing this, they actually promote parasympathetic arousal while decreasing sympathetic arousal, and therefore are sleep promoting. The author's overall aim of this study was to evaluate the effect of the chain blankets on insomnia and sleep-related daytime symptoms in patients who had depression, anxiety, ADHD, or bipolar disorder. Patients were included if they had insomnia for at least 2 months, and they had to score greater than 14 on the Insomnia Severity Index score, in addition to having one of the 4 psychiatric conditions listed here. They were excluded if they were actively using drugs, if they were overusing their sleep aid medication, or if they had some underlying condition that affected their cognition, such as dementia or acquired brain injury. The primary outcome that they assessed was a change in the Insomnia Severity Index score. Secondary outcome measures that they looked at were the Fatigue Symptom Inventory Questionnaire score, the Hospital Anxiety and Depression Scale score, and symptoms reported on day and nighttime diaries. Participants were randomized in a 1-to-1 fashion to a weighted group and a control group. The weighted blankets weighed between 6 and 8 kilograms. The control group used blankets that had similar shape but plastic chains sewn into them, and these blankets weighed about 1.5 kilograms, and this was within the average range of blankets that you would get at a regular department store. There were 2 phases to this study, the control phase and an open continuation phase. The control phase was the first 4 weeks of the study. All participants essentially filled out all of these questionnaires and wore actigraphy for 1 week. And then as each week went on, participants filled out the ISI questionnaire on a weekly basis, and then during week 4, all participants filled out all questionnaires again and repeated actigraphy during the 4th week as well. After that point, all participants were given the opportunity to use weighted blankets and followed up to 12 months. Overall, there was 120 participants enrolled in this study, 64 of which were in the weighted blanket group and 56 were in the control group. The age ranged between 18 and 77. There were more females than males enrolled. When they looked at the breakdown of the weighted group versus the control group from a demographic standpoint, their underlying psychiatric diagnoses, and the duration of their sleep symptoms, there was no statistical significant difference between the 2 groups, so the 2 groups were similar. When they looked at their primary outcome measure, which was again the ISI score, what they found was in participants that used the weighted blanket, after 4 weeks, they found a statistically significant reduction in their ISI score. In fact, they found this result even less after just 1 week of use. When they looked at their secondary outcome measures, to include the fatigue symptom inventory and then their depression and anxiety symptoms, those who used the weighted blanket also had statistically significant reduction in these scores. Also, I didn't highlight these, but you can see here when they broke down the participants by their underlying psychiatric condition, regardless of their condition, they also had a statistically significant reduction in their ISI. In Figure A, this basically shows from a more visual standpoint on what was discussed on the previous slide. On the y-axis is the ISI score, and then on the x-axis it's broken down by control phase and open phase. The blue circles are the control group, the orange triangles are the weighted blanket group. And as you can see here, from the beginning and on throughout the study, there was a statistically significant decrease in their ISI score. And into the open phase, this was seen when all participants continued with the weighted blanket. Figure B looks at the responder rate, which the authors defined a response as a greater than 50% reduction in their ISI score. And as you can see here, those who used the weighted blanket had much more of a responder rate than the control group. When they looked at the weighted group versus the control group, they did find that there was no significant difference in their total sleep time or their wake after sleep onset time. However, subjects still reported subjectively that they had improvement in their sleep maintenance. When they looked at actigraphy, they also found that those who used the weighted blankets had a higher level of activity throughout the day compared to those who did not. They then did a subgroup analysis, which they compared responders to non-responders. And when they broke down the groups in that fashion, they did find that there actually was a significant decrease in the wake after sleep onset time and sleep maintenance seen in those who were responders. So overall, this study demonstrates that the use of weighted chain blankets as an alternative for treatment in adults with insomnia who have underlying comorbid psychiatric conditions can certainly be considered given the statistically and clinically meaningful effects that they found in their study. There were some limitations of this study. There were more women than men. However, insomnia tends to be more prevalent in women, so that could explain this. There was a slight risk of disclosing the blanket type to the rater. However, this only happened one time because a subject told the rater that their blanket had set off the alarm at an airport. Additionally, more of the gold standard PSG was not included in this study. However, there were a number of strengths. It was a randomized study. There was a relatively large cohort. And the results that they found were, again, independent of the underlying psychiatric diagnoses, which makes the results more generalizable across the board. And additionally, they were able to not only just include subjective data, but they were also able to include objective data with the use of actigraphy in their study. That concludes the first article.
Thank you, Dr. Hediger. That was a fantastic presentation. I really appreciate that. So I think this is like the hardest kind of study to have a placebo for because, even the plastic chains have a little bit of weight, right? But they did a good job with that. And I also noticed there might be a little bit of a placebo effect over time where the patients are getting better because they think they're being treated, which I know is a common issue in the psychiatric fields in general, but not really a question, just more of a comment. So I appreciate
Roger,
that.
sir.
All right, go ahead and we'll go ahead and finish the last article.
Okay. The second article that I chose to discuss was actually published in May 2020, also in the Journal of Clinical Sleep Medicine. And this study was, again, a randomized trial as well as a validation study on the use of a wearable sleep tracker in healthy participants. And I chose this article because the wearable devices are basically a hot topic. The overall aim of this study that the authors wanted to look at was if in healthy participants that they wore a wrist sleep tracker, did they perceive better sleep quality? Additionally, they wanted to validate this device and see if it was accurate in measuring sleep quality as well as sleep quantity when compared to a PSG. But again, in this study, they only included healthy volunteers. The device that they chose to evaluate was the Strap 2.0. Participants were included if they were between the ages of 18 and 45. They were excluded if they were found to have any kind of underlying sleep disorder, to include an AHI of more than 15 events per hour. They were excluded if they had any history of substance abuse, if they were pregnant or lactating, if they were using any kind of sedative medication, if they had any kind of chronic medical conditions, as well as if they had a BMI greater than 26. The primary outcome that these authors were looking at was the PROMIS questionnaire sleep disturbance score. And basically, that is the patient-reported outcome measurement information system sleep disturbance questionnaire that basically was a short version of this questionnaire and required 8 questions to fill out about their sleep. But the authors had the participants fill it out at baseline and then at 7 days and 14 days. They were able to get 32 participants randomized out of their goal of 35 into groups 1 and 2. Group 1 wore the device as well as maintained sleep logs for 7 days. In group 2, they just maintained sleep logs only. After the 7 days, everyone underwent a PSG while wearing the device. After the sleep study, they then switched groups so that group 2 wore the device and maintained sleep logs, and group 1 maintained sleep logs only for an additional 7 days. When authors looked at the PROMIS sleep disturbance score, again, that was their primary outcome, what they found was when participants wore the device, there was a statistically significant reduction in their score, indicating that when they were wearing the device, participants perceived better sleep quality. When they looked at their total sleep duration, however, this was actually unchanged while wearing the device. In fact, the duration actually was lower while they were wearing the device. When they looked at physical activity, they did note an increase when participants were wearing the device, but this was seen more so in men than women. During the validation part of the study, they had 2 separate scorers complete the PSG portion, and then they compared it to the data that was obtained from the wearable device. When they looked at sleep duration and sleep fragmentation, what they determined was that there was relatively low bias error and precision error between the PSG and the wearable device. They also looked at heart rate variability and respiratory rate. And again, in this instance, they also found between the 2 methods that there was, again, low error and low bias error and low precision error. So overall, this study showed that certainly a wearable device can lead to improved perception of sleep quality in healthy participants. And this was again determined by the significant reduction in their PROMIS score, which turned out to be actually of moderate effect size, so it was clinically meaningful. The authors hypothesized that potentially the improved quality of sleep that was perceived may have been due to the decreased sleep duration. So during the study, the device would send data to either the participant's cell phone or a tablet giving them recommendations, and potentially by reducing their total sleep time, this may have been similar to the sleep restriction that's used in CBTI, and that may have led to the improved quality of sleep. Additionally, they thought that perhaps the increased physical activity could have contributed to the better sleep quality that was perceived, but again, this was seen more so in men than women. Again, in conclusion with the validation study, this device was certainly considerably accurate when compared to a polysomnogram. However, technology is always rapidly evolving, so it's difficult to keep up with these kinds of validation studies of the technology that's available. There were some limitations. Certainly the study had a smaller sample size, and they had no long-term effect measured during this study, just short-term. And again, this study was limited to only healthy patient population and not those that we commonly see in the sleep disorder clinic. And that is the conclusion of that article.
Hey, thank you. That was wonderful. So the patients didn't actually have better sleep, but they perceived that the sleep was better. That's a very interesting observation.
Yep.
So it's like a placebo effect when you get these devices. One wonders if that effect wears off over time, like as it becomes not so novel to have.
Agreed. I think they do need to kind of follow it more long term to see if that's maintained or if it was, just short term.
Yeah. We did have one question about the weighted blanket study.
Okay.
The question was the amount of insulation the same between the blanket types? So I guess was one warmer than the other? Was the only difference the plastic versus the metal chains?
That's a good question. And the authors actually don't report that data. They only report the weight. They didn't report the type of cloth that was used or anything like that.
Okay. All right. Well, thank you again. And I want to thank all three of our fellows. These were fantastic presentations. You guys did a great job. And very importantly, we're on schedule. So I'm going to turn it back over to Dr. Brown. Or to Catherine Buki, sorry.
Either is fine. Good morning. I'm Catherine Buki. I'm